Hello, I'm John Kanalopoulos, an eye surgeon based in Athens, Greece and New York City, New York. I'm very excited to present to you our intrinsic technique. We introduced this technique in 2004 and it complies of topography-guided LASIK for hyperopia. The core concept in this is the fact that hyperopes have a significant angle kappa. This has been published in the literature and we have a collaborative paper with the University of Ankara showing the significance of angle kappa in hyperopes. So traditionally we have been performing LASIK centered on the pupil of those patients. The problem in these cases is that LASIK should be centered on the visual axis of these patients. I will show you a placido disc topography map giving you the relevance between the aperture of the pupil and the actual center of the cornea in these patients and why is it relevant to center on the visual axis. We are using the Wavelight platform for many years. The current version is the refractive suite by Wavelight Alcon, which very eloquently will perform with the FS200 laser the femtosecond flap, which also needs to be decentered on the visual axis of the patient, which usually is nasally and slightly inferiorly, and how the femtosecond will help us design this. And then the EX500 excimer laser that receives input from 5 topographic devices. The device we'll use the input here is from the Pentacam HR, which in Wavelight terms is called the Oculizer 2. So you see this attempt to perform a high hyperopic correction, topography guided in order to include the deviation of angle kappa, and also close the procedure with the procedure we have also introduced, prophylactic cross-linking, LASIK extra in today's terms with the Avidro device, that we have found, and we're presenting data at this year's ASCRS meeting, to become extremely helpful in stabilizing the hyperopic correction, possibly by modulating the biomechanical response that hyperopic eyes have after LASIK. I hope you find this presentation interesting, and I thank you very much for your attention. This is an example of hyperope on the Pentacam normal cornea, but if you study the placido disc images, you can see that the pupillary aperture is eccentric to the visual axis. Clearly, the visual axis is skewed nasally on this right eye. We're using the refractive suite, the FS200 femto on the left, the X500 on the right, and here is a standard hyperopic correction treatment plan. You can see how the pupillary aperture, as captured by the topographer, will be in the center here. On the right eye, topography guided, you can clearly see the decentered place of the ablation, and more clearly here, that though is centered on the visual axis of the patient. And again, we're going to the surgery video. This is both eyes of this hyperopic patient. We'll see the treatment data in a few seconds. You can see we're talking about a very significant hyperope. We're at a +7, minus 1.5 astigmatism that we'll be treating and directly into surgery. The patient interface suction goes on right now at this moment that the FS200 patient interface touches the cornea. Please note, compared to the pupil, how the ablation looks decentered to the left, which is nasal. And you can also see here on the report from the FS200 the actual femtoflap. And now I'm showing you here the pupillary aperture and how the flap is decentered nasally to match our topography-guided treatment. Single-use irrigation spatula. I just use one instrument in the LASIK procedure. Carefully return the flap, reflect the flap onto itself, and here you can see the hyperopic ablation, and again how it fits perfectly in this 9mm femtoflap. And now a drop of riboflavin solution. We leave it into the interface for about 60 seconds. We irrigate the residual, a drop of Pret Forte, and a Justin applanator to bring the flap back in place. You can see here how clearly the ablation gutter is also decentered nasally compared to the pupil. And now the Avidro KXL device and LASIK extra, 60 seconds of 30 milliwatts per square centimeters, and a bandage lens at the end of the procedure. This is the patient the day immediately after the surgery. You can see the bandage lens and the hyper-reflective interface. You can see here the patient postoperative at 1 week and at 1 month very stable refractive result, 20/20 uncorrected despite of the high correction. Here on OCT several months later, you can see the hyperreflective interface depicting cross-linking. Again, before and after our current routine in hyperopia, topography guided and prophylactic collagen cross-linking. Thank you very much for your attention.